So I'm delighted to introduce Grand Rounds today, which is a special Grand Rounds. It gives us, I think, a great deal of pride, those of us in the education space, to see our residents who have been role models in demonstrating the critical role of physicians as champions for health equity and leaders in the health equity space. They have taken on ownership over advocacy, over education, and really numerous different aspects of this. And I'm so incredibly proud and humbled by the work that our residents have done. One of those residents is our speaker today, and that's Dr. Mark Spencer, who is a second-year resident in the internal medicine primary care program here. He is currently enrolled as a resident in the social medicine distinction and the health equity advocacy and policy track, and is an active member of the CDIC advocacy branch. And the CDIC is our Churchwell Diversity and Inclusion Collective that is a resident-run organization. Mark graduated from Hopkins with a major in neuroscience. He then went on to teach middle school math in Chicago prior to medical school, which he attended at Georgetown University in Washington, D.C. Since then, or including then, his primary interests lie at the intersection where public health meets the crises of American policing and the carceral systems. Specifically, he's interested in how healthcare workers aid in offering human-centered, preventative-focused, and equitably designed interventions that minimize harm and are not punishment-based for our justice-involved individuals. He has developed a talk about this that has really received accolades and came to my attention. And so I'm thrilled to be able to offer this to the department. And so Mark's talk will be entitled Policing, Incarceration, and Health Equity, Viewing Public Safety and Justice Through a Different Lens. And Dr. Spencer, thank you so much for joining us and speaking to us today.
Yeah, thanks so much for inviting me. I'm really excited to get started. Let me just pull up a presentation. And we can get going.
Looks perfect.
So today, like Dr. Armstrong said, I'm going to talk about policing, incarceration, and health equity. We'll be discussing medicine from a systems perspective and looking at how poorly designed systems can result in catastrophic outcomes. While some of this information is quite heavy, I hope you'll find it both personally challenging and thought-provoking. There's a lot to cover, so let's dive right in. Our learning objectives for today will include understanding the demographics of those disproportionately policed and incarcerated, understanding how policing and incarceration serve as barriers to health equity. We'll look at some of the challenges to providing adequate healthcare in carceral facilities. We'll also analyze the public health implications of policing and incarceration. And briefly, we can discuss interventions that can move us towards a more equitable society. To start, there are a few overarching frameworks we should keep in mind throughout the talk. First, our focus should always be on harm and not crime. If health equity involves a common goal of everyone living healthy, safe, and the most fulfilling life, crime is simply not a useful unit of analysis. We care about harm, the negative impacts on individuals and communities. It's important to note that what is deemed criminal is politically constructed by those who have power and have interest in keeping it. Many harmful actions are not deemed criminal, and conversely, many crimes are not particularly harmful to anyone in particular. We should also focus on systemic outcomes and not individuals. Policing is a system like any other, a system that was chosen and invested in over time, and certainly not inevitable. All of us being in the field of healthcare should understand how good intentions alone are not enough to overcome poorly designed systems. We should examine the idea of policing as public safety as well. Despite what can seem like endless pop culture depictions, political statements, and even painted on the police cars themselves, the claim that policing exists to promote public safety is deeply flawed. We'll interrogate this claim more and look to understand how policing is better described as a tool for maintaining the status quo. Lastly, we should question the premise that punishment is justice. Punishment often reproduces the very harm we hope to reduce. What we should work for is accountability, which includes repair. We must take an honest look at our individual and institutional relationships to punishment and how this is not compatible with a healing framework. We'll begin by taking a closer look at policing, often the entryway to the legal system. Let us keep this quote in mind. The true measure of our character is how we treat the poor, the disfavored, the accused, the incarcerated, and the condemned. And that was said by Brian Stevenson. First, policing negatively impacts mental health. Various studies have shown that unwanted contact with police is psychologically distressing. In fact, it's been linked to multiple negative health outcomes, including increased rates of depression, anxiety, and PTSD, even in the absence of any physical force. This disproportionately affects Black Americans as they are subject to far higher levels of daily surveillance, and data strongly suggest that policing itself should be considered an adverse childhood experience. The vast majority of these interactions do not lead to any arrests and are unnecessarily traumatizing. Policing also causes physical injury. Estimates of over 75,000 injuries brought to the emergency rooms annually grossly underestimate the true rate of physical harm caused by policing. As we will discuss, there's little oversight for data collection, and policies differ among the more than 18,000 police forces in the United States. As seen in this picture, this is partially a consequence of the militarization of police forces. This militarization has taken place over the past 3 to 4 decades and includes billions of dollars in excess military weapons and equipment transferred from the federal government to local forces. This in turn reinforces the idea that police are at war with the community versus a part of it. Most devastatingly, policing kills. Police kill a horrifically high number of people year after year. In 2021, that number was 1,134. It is extraordinary that this fact is either not widely known or has been normalized and rationalized. It's estimated that 1/3 of people murdered by a stranger are killed by the police. Additionally, only 1/3 of the victims of police killings were killed during an alleged violent crime. The vast majority of these deaths occur during seemingly benign interactions such as traffic stops. It is perhaps unsurprising that the physical and psychological violence of policing falls disproportionately on certain vulnerable and marginalized groups. This includes the mentally ill. People with mental illness are 16 times more likely to die during a police encounter. Disturbingly, 1 in 4 killed by police had a mental health illness, and often these interactions were initiated in hopes of helping the individual. These facts are directly related to our failure to provide any semblance of a robust and equitable mental health care system. In Georgia, we are last to access in mental health. Policing also disproportionately affects people of color. People experience police interactions vastly different based on who they are, based on race, income, appearance, among other factors. A recent survey showed that Black and white individuals had opposite fear responses to police interactions, with Blacks responding very afraid versus white people saying very unafraid. This severe distrust and anxiety around police interactions stems from decades of abuse and the ongoing disproportionate surveillance and criminalization. In fact, Black individuals are stopped, searched, arrested, and met with force at higher rates, 3 to 9 times based on the study that you look at. It's very young people that bear the brunt of this, with people as young as 12 reporting symptoms of PTSD due to this traumatization. Both Indigenous people and Black people are far more likely to be killed by the police, despite being less likely to be armed. Another group disproportionately harmed by policing are transgender people, in particular, transgender women of color. An Atlanta-based survey by Solutions Not Punishment found 80% of transgender women of color were stopped by police within a year's period of time. 40% of those who called the police for help ended up being arrested themselves. It is medically and ethically bankrupt to put transgender women in men's prisons, but this happens routinely. It's extraordinarily dangerous and has led to high rates of sexual violence. often inflicted by correctional guards themselves. Of course, jails and prisons will rarely provide gender-affirming care or proper medications. This further traumatizes and contributes to the higher rate of death by suicide among transgender individuals. If for a second, you may think the high rate of harm inflicted by policing is unfortunate, yet commonplace and unavoidable, let me disabuse you of that notion. The number of people American police kill is unprecedented in modern democracies. These numbers from 2019, even when adjusted for population, show that America, year after year, kills its own citizens at a rate, for instance, 30 times that of Germany. It's hard to comprehend how this has been deemed acceptable. With so much documented harm by policing, we should be asking, is policing worth it? Despite the tie-in of police to crime reduction, which is not to say harm reduction, when 60 years of data were analyzed, there was no correlation found between either funding for police or police force size and the crime rate. As David Bailey, widely regarded expert on policing and crime, puts it, the police do not prevent crime. Experts know it, the police know it, but the public simply does not know it. When we take an even closer look at the data, it is particularly revealing. Not only is policing not a preventative intervention, it fails to address the vast majority of crime and harm after the fact. To start, less than 50% of crime is even reported to the police. Out of the crime that is reported, police spend less than 4% of their time on violent crime. When we look at two of the most serious forms of interpersonal harm, the statistics are devastating. For every 100 sexual assaults that take place, only 1 to 5 will serve a prison sentence due to arrest by police. This is our primary intervention at addressing sexual violence, and it's failing miserably. In fact, it does not seem to be particularly high on police priorities either, as hundreds of thousands of rape kits are frequently untested. Perhaps unsurprisingly, police routinely solve less than 50% of murders. This is based on their own biased data and clearance rates as well, meaning a significant portion of those solved will not lead to any formal consequence. Additionally, police violence itself is overwhelmingly not included in these statistics, since it is almost without fail deemed legal. It's not widely known that police themselves take more money from communities via civil asset forfeiture than all burglaries combined. This includes people's cars, homes, anything that can be presumably tied to money from crime. In practice, this looked like a massive transfer of wealth from already poor communities to the police, funding new police gadgets and Christmas bonuses. Police, of course, do spend their time doing something, much of which is harmful and not evidence-based, including enforcing the war on drugs. There is irrefutable evidence that the war on drugs has been devastating, especially to marginalized populations both in the United States and abroad. Despite this fact, and in direct opposition to public health consensus, drug possession remains the #1 arrest by police. This of course does not take place on places like college campuses, where drug use is equally rampant, but in communities where heavily police surveillance takes place. When we acknowledge that policing functions not to reduce harm, certainly not to prevent it, but to control certain populations, we start to understand that policing is not necessarily broken, but functioning as intended. This mass criminalization leads to significantly worse health outcomes. Criminalization is a clearly documented driver of the overdose crisis due to a lack of predictability in the drug supply, and it has empirically been shown to contribute to community-based gun violence as well. In Georgia, we recently saw over 1,400 overdose deaths. The criminal punishment system goes against almost all public health recommendations for effective drug treatment. This includes policies such as coercive and mandated treatment, required abstinence programs, and often the refusal to prescribe opioid agonist therapy, like buprenorphine. These uninspiring numbers are certainly not for the lack of funds. We invest much more heavily in punishment and surveillance compared to public health priorities. This begs the fundamental question as to what we are gaining from this unprecedented investment in policing. There are countries that spend far less in absolute and relative terms on punishment and are both far safer and healthier. In fact, we spend so much on policing, the US police force is the third highest funded military in the world, with this data being a few years old. The opportunity cost of these funding decisions, especially over the past 60 years, is unfathomable. Incredibly, despite all of this harm, and with little positive outcomes to show for it, the institution of policing has been deemed so vital to public safety that it operates with almost zero accountability. The government does not even track how many people it kills. Death rates are so poorly counted that over the past 40 years, they left out close to half of them in official statistics. The Department of Justice simply didn't publish excess use of force summaries as required by law in the past 4 years. Additionally, a new task force within the FBI, tasked with gaining all use of force reporting from local departments, is at risk of being shut down due to very poor reporting percentages. There is little accountability at the federal level, and it's often worse in local jurisdictions. While there's no one cause to this lack of accountability, a few contributing factors include the doctrine of qualified immunity, law enforcement Bill of Rights, and police unions, which all serve the primary purpose of maintaining political power with little interest in public safety and it being used more as a public relations tool. Perhaps after seeing this data, it could be suggested we just need more police reform. The story of policing in America is the story of police reform. This list of a few commissions from over the years, often compiled after urban uprisings, consistently suggested that racism, inequality, and police brutality itself were the primary drivers of disorder. The overwhelming result of these commissions, however, has been to funnel more money to police departments to improve themselves. The suggestions to improve housing, schools, job opportunities have largely been ignored time after time. In fact, police reform is so ineffective at improving public safety because it's simply not the purpose of policing in the first place. An honest assessment of what police do and the outcomes they produce makes it clear they primarily function as managers of inequality. Policing has stood on the wrong side of every social movement in this country's history, from the abolition of slavery, the period of Reconstruction, Jim Crow, the Civil Rights Movement, and today, the movement to justly fund public services and life-affirming institutions. The most frequently talked about reforms, such as diversity hiring, improved training, including implicit bias training, and community policing initiatives, have been repackaged and tried many times over the past 100 years. Unfortunately, we are not a country that learns well from our history. And yet again, unable to divorce the idea of policing from public safety, the George Floyd policing bill, which the federal government has failed to even pass, would give hundreds of millions more dollars to local police departments, instead of addressing the root causes of inequality and violence. As with any intervention, we should continue to reassess and ask important questions such as, does policing reduce harm? Does it do so more effective than other interventions? Does the crime they focus on benefit society? And are the consequences of policing worth potential benefits? As we transition to policing's logical endpoint, incarceration, Daniel Surra's analysis is an important starting point. Incarceration is limited as a tool because it treats violence as a problem of dangerous individuals and not as a problem of social context and history. Poverty drives violence. Inequity drives violence. Lack of opportunity drives violence. Shame and isolation drive violence. And like so many conditions known all too well to public health professionals, violence itself drives violence. When talking about incarcerated individuals, we should not contribute to dehumanization with the words we use. This includes the terms we choose to document professionally in medical records and journals. We are not a profession that should identify individuals by a single decision they have made. We should avoid terms like inmate, felon, offender, convict, and instead center the human being. This can seem like a simple or even seemingly unimportant ask, yet language is a powerful tool in constructing narratives. To review briefly, a jail is a local institution intended to hold people pre-trial without a conviction or someone sentenced typically less than a year. Prisons are often far away from one's home and loved ones and hold those sentenced over a year. Other places that are typically considered carceral environments include detention centers for immigrants, for youth, and many involuntary commitment centers. The United States cages almost 1/4 of all incarcerated people in the world, despite representing less than 5% of the world population. That number is currently around 2.2 million people. This doesn't begin to tell the whole story, as over 12 million people churn through the punishment system annually. The vast majority, almost 90%, are through jails. The scale of this system is so massive that 77 million adults have a criminal record, and 113 million have had the traumatic experience of an immediate family member being incarcerated. In Georgia specifically, we incarcerate over 100,000 individuals. To put these numbers in context, there is not a country on earth that incarcerates its citizens at a higher rate than the US. Other Western nations do not even come close. Georgia specifically stands far above the US average, and only 3 states have a higher incarceration rate. Racism is deeply embedded in the criminal legal system. It was not until after the abolition of slavery that Black people actually became the majority of those incarcerated in the United States. It was at this time that many of the former slave patrols converted into Southern police forces, and their mechanism to exert control over Black bodies moved to mass criminalization and convict leasing. This further established the false link between Blackness and criminality that persists to this day. Black people are 5 times more likely than white people to be incarcerated. In Georgia jails and prisons, Black people are grossly overrepresented. Notably, incarceration overwhelmingly impacts poor communities. People in prison had a pre-incarceration income typically less than $20,000. In jails, the average income was even lower, with many making less than $10,000 or nothing at all prior to incarceration. This has devastating consequences for those unable to make bail and quite literally pay for their freedom, which is over 500,000 people on any given day in America. As Sister Helen puts it, those without the capital get the punishment. People who meet the criteria for a substance use disorder are also disproportionately incarcerated. The majority of carceral facilities do not follow public health guidelines and refuse to prescribe opioid agonist therapy. There have been documented deaths not just from alcohol withdrawal, but even opioid withdrawal due to dehydration. This shows a specific level of neglect, as we know this should not be a fatal medical condition. Due to the lack of treatment during incarceration and the lack of any serious effort to connect patients to care on reentry, overdose risk is extremely high for those leaving prison. One study found as high as 120 times in the first 2 weeks after leaving prison. Incarcerated individuals have a high chronic disease burden. This includes high rates of infectious disease, which are specifically important to note because carceral settings are notorious for spreading infectious disease and for often failing to treat them appropriately. It's estimated that 1 year incarcerated removes on average 2 years from an individual's life expectancy. Mass incarceration itself has been empirically shown to contribute to America's lower life expectancy compared to peer nations, and to Black Americans' lower life expectancy compared to white Americans. Despite the fact that the recidivism rate for elderly individuals approaches 0, our punitive policies have led to an aging population in prison, with over 1/3 of people expected to be over 50 in the next decade. While many of our elderly patients cannot find a safe place to live, there is seemingly no limit to the number of prison cells our country is willing to provide. In addition to the complex physical comorbidities, incarcerated individuals are 5 times more likely to have a mental health disorder. Carceral settings represent the near opposite of a therapeutic environment, and incarceration itself greatly exacerbates mental health. Despite this widely known fact, the largest 3 facilities in the US holding people with mental illness are jails. The facility's primary interventions for uncontrolled mental health disorders are further punishment and neglect. It is, in fact, an international human rights violation to keep people with mental health disorders in solitary confinement. Yet this practice is widespread in American jails and prisons. This includes here in Fulton County, where a settlement was just reached this week, condemning the neglect of many mentally ill women in jail, confined for 23 hours a day in a small room. Despite the health consequences, during COVID, a primary strategy to attempt social distancing was the increased use of solitary confinement at unprecedented levels. As we'll discuss, this did not stop the spread of COVID, but certainly traumatized a huge number of people. Incarceration itself is an incredibly traumatizing experience. This is counterproductive to public health in many ways, especially because over 95% of people will eventually leave prison at some point. In the end, incarceration produces premature death. Over 1,000 people die in jails annually, with over 3/4 of these individuals not convicted of any crime. It does not take a prolonged period of time to be at risk of premature death, as almost half of the deaths that take place in jails occur within the first week of incarceration. This is particularly true for the risk of death by suicide. In 2020, over 6,000 people died in prisons. And in 2021, Georgia prisons have documented at least 53 homicides, 44 suicides, and over 100 deaths from COVID. Almost none of these individuals were sentenced to life in prison, yet the state is largely responsible for killing them. Additionally, incarceration has devastating consequences for certain communities. The loss of a loved one to prison leads to significant physical, mental, and economic distress. Individuals with an incarcerated family member have a life expectancy 2.6 years shorter. 2/3 of family have trouble meeting their basic needs due to a family member's incarceration. And for women in particular, the fastest growing incarcerated population in recent years, they are overwhelmingly primary caregivers to children prior to their incarceration. With this data in mind, it is vital to interrogate the supposed usefulness of incarceration in promoting public safety. Out of the 4 primary purposes of incarceration empirically only serves 2. Retribution, certainly, as carceral settings are incredibly punitive and traumatizing. Incapacitation, although only temporarily, and at the cost of separation from family, friends, and community. Incarceration does not deter crime. This is a fact. Only the certainty of punishment deters crime, not the length of sentences and not even the death penalty itself. Lastly, any claim that carceral facilities serve a rehabilitative purpose is suspect at best. To succeed and/or change behavior in prison is to do so despite prison, not because of it. Over 50% of people incarcerated receive 0 programming of any kind. In fact, incarceration is an overwhelmingly poor crime control strategy. A recent 2021 meta-analysis from the University of Chicago showed out of 116 studies that incarceration had no effect on reoffending, and in fact slightly favored increasing the risk of reoffending. Additionally, higher rates of incarceration in certain areas are not associated with lower violent crime rates. Recidivism, or returning to prison after release, remains extraordinarily high due to the same reasons people are often incarcerated in the first place. Not only have none of the root causes been addressed, but now these individuals must navigate the added stigma and barriers of a criminal record. This nearly ensures the cycle of punishment continues. As civil rights lawyer Alec Karakatsanis says, desensitization has led to a remarkable lack of intellectual rigor in every corner of the punishment bureaucracy. Almost no one carrying out punishment in our legal system has any clue about whether what we're doing is leading to any good. Now that we've reviewed the considerable harms and misconceptions of both policing and incarceration, I would like to spend some time specifically looking at healthcare in jails and prisons. Incarcerated people are in fact the only ones with a constitutional right to healthcare in the United States. This largely stems from the case Estelle versus Gambell in 1976, which took place following an injury to an incarcerated worker. Deliberate indifference to the serious medical needs of prisoners was deemed to violate the Eighth Amendment. A 1987 appeals court decision elaborated on this right, stating care should be reasonably commensurate with modern medical science. The UN Nelson Mandela rules state that care should be on equal standard to that available in the community. With these vague protections, as with many things in the so-called justice system, the legal rights are far from reality. The most significant reason for this overwhelming is the overwhelming lack of transparency and accountability within carceral settings. Incarceration is an extraordinarily expensive endeavor with low estimates of around $30,000 per person per year. A primary means of cost savings was to turn to for-profit healthcare contractors who aim to control costs by providing minimum care, often with less staff. Two of the largest providers, WellPath and Horizon, have both faced tremendous numbers of lawsuits for poor care and preventable deaths. For example, here are just a few headlines from the past few years. Note the practice of failing to provide antiretrovirals, which should be unthinkable in 2022, but occurs regularly. And the prescription of ivermectin to people incarcerated in Arkansas continues the dark legacy of medical experimentation on incarcerated individuals. To understand why these problems persist, there are a number of issues with carceral healthcare. Perhaps most significant is the concept of dual loyalty. Being employed by a punishment facility, but trying to serve patients' well-being. This is particularly challenging given the fact that security always takes precedent. Additionally, as discussed, the budgetary pressures often keep medical staffing low and providers paying only for what they feel they must. As discussed, caring for this patient population is also challenging due to the frequent comorbidities, both physically and mentally. Unfortunately, even with caring and well-trained physicians and without a profit motive, it is near impossible to effectively do healing work. This is epitomized perhaps best by Rikers Island Jail in New York, whose medical staff is exceptional, yet over the past 6 months, yet again, has descended into an unprecedented human rights crisis. Additionally, there are barriers to care such as medical copays, despite the fact that wages, like in Georgia, are $0 and 0 cents for incarcerated workers. Another healthcare challenge is the fact that these are congregate settings, which leads to especially issues with infectious disease like TB and COVID. Ultimately, prisons and jails are highly stressful and traumatizing, and both physical and sexual violence remain commonplace. When we look at COVID specifically, its spread within prisons and jails remains one of the greatest public health failures of the pandemic. Despite early calls from advocates, we have largely ignored the call to decarcerate to a safe level. Incarcerated people are at over 5 times the risk to be infected and 3 times more likely to die from COVID. Throughout the pandemic, low-end estimates state that at least 40% of incarcerated people have been infected with COVID. Due to the tremendous number of people coming and going from these facilities, they have greatly contributed to community spread as well. One study found Cook County Jail in Chicago responsible for roughly 1 out of every 6 cases in the city. Perhaps the largest contributing factor to these failures is the ongoing refusal to decarcerate at a large scale to decrease COVID spread. This, of course, is political in nature, as no one wants to feel soft on crime. The most logical of these measures would have been to release those held pre-trial who haven't been convicted of anything. This has not happened. Another avenue would be compassionate release for the medically vulnerable. The Bureau of Prisons, at the start of the pandemic, despite no vaccines for protection, denied 98% of applications. From the beginning, many incarcerated people could not access masks, soap, and social distancing remains near impossible. The CDC itself failed to prioritize incarcerated individuals for vaccination, despite the well-documented risk. Additionally, carceral staff have one of the lowest vaccination rates of any profession and have adamantly opposed vaccine mandates. Additionally, due to the tough work that they're doing, staff have quit en masse or are simply not showing up to work around the country. This is making it very difficult to continue the basic operations of prisons and jails, including getting people to and from medical appointments. Disturbingly, as Professor Brinkley put it, we basically know nothing, and it's really disheartening in that we have less and less data every day. There's no accountable, non-biased mechanism for reporting information. Georgia, for instance, simply stopped reporting cases and deaths in July of 2021. With this knowledge at hand, let us now look locally, where we have the most at stake and the most opportunity to affect positive change. In Atlanta, our policies have overwhelmingly failed to follow the evidence. For instance, there's been a failure to decarcerate during COVID in jails, as discussed. The Atlanta City Detention Center, which was supposed to be closed and converted to a wellness center, is still actively caging people. Far from defunded, police funding continues to rise year after year, now consuming over 1/3 of the city budget. The current public safety strategy lies mostly with hiring 250 more police officers, despite no evidence that more officers will lead to a net benefit of less harm or more safety. Additionally, the police are actively raising a force to create what has been referred to as Cop City, a new training facility, which will cost over $80 million. It is near unthinkable that we would make these long-term investments in institutions that fail to produce evidence of their effectiveness. While, for instance, 80% of Black children in Atlanta still live in concentrated poverty, and the city consistently ranks in the top 3 most unequal cities in America. Addressing both of these latter facts would, of course, more effectively reduce violence and harm, yet more policing will undoubtedly exacerbate them. For those unfamiliar, 2 of the primary jails in Atlanta are the Fulton County Jail and the Atlanta City Detention Center. DeKalb County, as with most counties, also has its own jail. A brief look at the history of these institutions is instructive for contextualizing the present. ACDC was built prior to the Olympics, largely to remove visible signs of poverty and neglect. It previously held many immigrants as well in partnership with ICE, which was ended in 2018. In 2019, a large group of organizations, the Reimagining ACDC Task Force, worked with the city and formed plans to convert the jail to a center for wellness and freedom. This has not yet happened, and we still are spending $30 million a year to cage less than 100 people with crimes related to poverty, such as minor traffic violations. Fulton County Jail, on the other hand, was built in 1989 and has a long, troublesome history of abuse and neglect. For instance, court oversight was put in place in 1999 for the jail's failure to provide proper care to HIV patients. In 2005, court oversight was again put in place, this time for overcrowding and neglect. Because of the court oversight in 2005, over the next decade, $1 billion was put into improving the jail. Despite this massive investment, not much has changed. In 2020, despite COVID, the jail remained overcrowded, one of the primary reasons for the federal oversight the decade prior. In 2021, instead of allowing people held pretrial to stay home, which has been shown to not increase crime rates, they are paying neighboring jail in Cobb County to hold the people instead. Here are many of the organizations who have worked tirelessly to repurpose ACDC and end the criminalization of poverty in Atlanta. Notably, there lacks any healthcare or hospital representation, who remain either blissfully unaware or lack the political courage to follow evidence and state incarceration is not going to make us safer or healthier. For our politicians, it is political malpractice to endorse policies that cause no one harm while lacking any evidence for substantial benefit. This continues to write a public narrative that policing and incarceration will create safer communities. From our perspective in medicine, an expensive intervention that produces questionable outcomes is a scandal. If that intervention also produces mass death, it would be universally condemned. We have spent a considerable amount of time on the extensive harms of policing and incarceration. This information can feel both infuriating and overwhelming. I do, however, remain hopeful. When we refer to health equity, we mean simply that everyone should have a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. This quote, of course, is referencing not only the social determinants of health, but also the social determinants of much criminalized behavior, which are largely one and the same. I believe that we can leverage the building of robust public health institutions to move away from the harms of policing and incarceration. What is encouraging is that we are far from starting from scratch. We already have tons of evidence on ways to prevent and minimize harm. This, of course, requires a focus on prevention. We must aim to develop policies from a life-affirming perspective, emphasizing that no human being is disposable or irredeemable. We have to discard the idea of policing as the solution to violence, let alone every societal ill, as evidence does not support this. Different issues deserve tailored interventions from people with specific skill sets. As healthcare providers, we must personally and institutionally reckon with our American addiction to punishment. We know it harms patients, is not effective in increasing safety, does not transform individuals for the better, and makes us all less healthy and safe. We must also vocally denounce the false choice between police or nothing. What people want is safety, and there are limitless interventions to bring us that goal. In addressing violence specifically, the John Jay Research Center recently identified 7 areas that have evidence for reducing violence without police. This included interventions as simple as improving the physical environment, community youth outreach and support programs, and mitigating financial distress of families. Additionally, all of the organizations listed here exist around the country and work to prevent violence and increase community safety. We unfortunately do not have the time to look at all of them. My point simply being, communities are finding ways to address violence outside of the legal system. Most of these groups have data supporting their use without the considerable harms of policing. Of course, they do operate with a tiny fraction of police budgets. Additionally, here are 2 models, both with explicit ties to healthcare. Cure Violence, which was started in 1995 by a doctor in Chicago after working with the World Health Organization around the world. They believe strategies for disease control could potentially work for violence. Cure Violence has multiple studies from locations around the world showing it lowers violence effectively. Another program is the Health Alliance for Violence Intervention, which I believe Dr. Smith is working on bringing to Grady. This intervention takes place often in trauma hospital bays and has been shown to decrease violence by providing well-rounded community-based services and support. The #1 way to minimize the negative effects of policing is to decrease the number of interactions people have with them. Alternative responder models are tremendously effective for this purpose. Given that 9 out of 10 calls are for non-violent concerns anyways, there's little need to send an armed agent of the state. By using specific responders with specific skills, we can better tailor interventions and responses to needs, all without the risk of state violence. CAHOOTS, one of the longest and most successful models of this concept, covers 20% of all emergency calls, and only a tiny percentage result in police presence. The response team has specialized harm reduction and mental health training. In contrast, the STAR program in Denver relies on police themselves to triage the calls. This has led to only 3% of calls being diverted. These two examples show some of the significant downsides to working within the criminal legal system itself, despite this often being the path of least resistance to funding. This means that we should be cautious of co-responder models, which always include the police, versus having separate, independent public health initiatives and responders who have their own funding mechanisms. In Atlanta, one program that helps to decriminalize poverty is an outreach team that will respond to vulnerable individuals with mental health, substance use, or extreme poverty concerns. Policing alternatives and diversion also provides an example of the difficulty in working in partnership with the existing punishment bureaucracy. For instance, over a 3-month period, despite 432 people eligible for diversion, only 24 were referred. A top charge of these individuals was walking in the roadway. We should be looking to partner with and scale PAD's mission, while advocating for them to have independent and well-funded resources. We must also expand harm reduction, which we know can save lives. Drug policy will always provide the most clear examples of the differing goals of public health and the legal system. Instead of billions spent on criminalization, we should vastly expand access to Suboxone and methadone. Additionally, we need to fund and expand other resources, such as widely available needle exchanges and safe injection sites. We should vocally partner with organizations to push for the decriminalization of drugs as a sound public health intervention. This is not only more humane and the right thing to do, it is cheaper and leaves more resources to invest in communities elsewhere. Overall, we need to ensure that everyone can meet their most basic needs. Instead of providing the 40 million Americans in poverty with multitudes of police and prison cells, we should invest in their well-being. It is well documented that lower rates of inequality are correlated with less substance use disorders, mental health disorders, and homicides. Even the simple act of expanding access to care via Medicaid expansion was shown to lower violent crime. Working towards widely available and affordable care for all will greatly reduce physical suffering and inequality. We must be more intentional at building a healthcare system based around equity and justice and not profit and charity. Additionally, a recent large study looked at 53 studies, and all of them showed interventions that can maximize people's ability to thrive and all leading to lower crime. This included investments in childhood education, housing provision, and employment programs with livable wages. In the end, this all begs the question of what exactly are we doing and where do we fit in all of this? No single intervention or policy change will be a panacea to ending harm. We need, in fact, hundreds and thousands of different interventions to meet the specific needs of people in different places. We need a tremendous amount of creativity and community building. Dr. Reinhardt says that although they treat the sequela of poverty every day, doctors in the United States have historically failed to use their collective influence to address political ideologies of disease. What world could we have if we organized with our most marginalized patients and centered their needs and demands? One simple place to start is our own institutions. We should look to evidence to guide our policies, and we should scrutinize policies that largely have no evidence base, like those around the care of incarcerated patients who come to us from the jail. We should aim to work much more closely with jails and prisons health providers in our city and state, and keep our hospitalized patients from returning to those traumatic environments whenever possible. We should organize and advocate with many of the local community groups who are constantly fighting an uphill battle against mass criminalization and provide an additional voice in public health lens. We should create mechanisms to bail out incarcerated patients who are simply held pre-trial and too poor to make bail. And we should eliminate discharge to jail as an acceptable thing to document, especially during the COVID pandemic. We should contribute to building much more robust re-entry support for individuals who have suffered the health consequences of prison. And we should push our public leaders to invest in care. This could look instead like 250 new community health workers, patient care navigators, home visit teams, and free publicly funded mental health professionals. There are, in fact, endless amounts of ways for us to combat mass criminalization and incarceration in our communities. We should support the elimination of any low-level arrest and jail time for crimes of poverty. This includes the elimination of cash bail. We should, of course, support the decriminalization of drugs, even while realizing that even releasing everyone incarcerated on a drug offense would still leave us with the highest incarceration rate in the world. We cannot shy away from building alternative methods of preventing and addressing violence itself. In this respect, we should look to and learn from many organizations building models of restorative and transformative justice, where the focus is on meeting obligations and repairing harm, as well as on transforming the conditions that allowed harm to take place. I want to end by looking forward. Mariam Kaba reminds us to begin not with the question of what do we have now and how can we make it better? Instead, let's ask what we can imagine for ourselves in the world. Thank you so much for listening. And I want to thank my editors, my wife Hannah and brother Scott, Dr. Armstrong, of course, for the opportunity, Dr. Fluker and Dr. Law, my program directors. Shout out to the Primary Care Track fam and for CDIC for giving me a space to discuss some of these issues. And of course, to all the community organizers and educators who inspire me to envision a different and more equitable world. Thank you.
Thank you, Mark. Thanks for that, for presenting the evidence and really giving, I think, many people a lot to think about. I know that for many, there may be some moral distress listening to what you're presenting on this call in all kinds of different, or on this talk in all kinds of different directions. And it seems overwhelming to think, how do we go from where we are now to a place where we have the kinds of social supports that would make a really different framework possible. To start out with, what advice would you give to the person who wants to apply this knowledge directly to patient care, as we all are involved in that? What's an individual thing that anyone listening to you today could do?
Yeah, I think the easiest thing to do as an individual is to educate yourself, because there's so much misconceptions around these issues, and most of us physicians don't personally suffer from these systems. And so, hearing directly from communities and directly impacted communities who do, of course, a lot of writing and publishing is the best way to learn and contextualize some of these issues, because we can't really, move forward with advocacy and policy if we don't really have the understanding of the basic facts at hand.
That's, I think, a really important point. And are there any examples or countries or cities or places that have moved from really a very crime-based approach to something that is, more like a future the future that you described?
Yeah, I think that it's not hard to find another country doing things better, but I don't think anyone's doing it perfect. And I think a lot has to do with, fear and using, really horrific examples that then drive politics. So we need to somehow, divorce our policy building from being responsive to, these public narratives of crime, which is what, Rachel Barkov writes a lot about. And so I don't really know that there's anyone doing it perfect, but the best example is just when you invest in people and communities, that outcomes are extraordinarily different and better, because most people are deterred from stealing food or stealing money because they just simply don't need to, right? And so, like, if we made that a reality for everyone here, which would actually be extraordinarily easy, despite maybe not politically feasible, we would have a vastly different, country.
And I think, there's been so much discussion about quote unquote defunding the police. And I think there's, really strong reactions to that. And I think that many see the alternative as a policeless world that is one of anarchy. and fear that things could happen to you without a protector. How do you help? What do you say to someone who is afraid of not having a police force? How do you help that person think about things a little bit differently? Because I think people always have valid viewpoints for coming at what they believe, and it's often out of personal fear or rather than huge differences of opinion.
Yeah, I think that's a great question. I think that's a question I myself had not too long ago. I think it's the logical question for anyone that's grown up in a society that is fundamentally built around polices and prisons as safety mechanisms. And my first answer would really be, well, I mean, all the violence that's taking place and that you're scared of is taking place right now. That's on the police's watch. So I don't really know what you're so scared of getting rid of, right? And in relation to that, it's not about just removing these institutions. It's about building institutions that will actually be effective and addressing it. So, it has to do with just completely transforming what we have. Because of course, if we live in the world of inequality, poverty, and despair that we have now, and without police, of course, violence will still be around, right? And so we need to address all of those factors simultaneously as we work, with harm reduction techniques to essentially minimize, the interactions between police and between people, and really, really drastically reduce the times that we're using incarceration as a quote unquote public safety strategy.
Well, we are at the top of the hour. I want to thank you so much for taking time to deliver this talk, and thank you for really helping, I think, everyone think about this topic in a way that many haven't thought about before. So thanks, Mark.
Yeah, thank you.